Good morning from all around the world, and thank you for being here today. I'm broadcasting directly from the Mount Sinai. I'm broadcasting directly from the Mount Sinai Fuster Heart Hospital in our structural heart life cases. My name is Pedro Moreno. I'm a professor of medicine, and I'm also an interventional cardiologist, and I will be your moderator today. We will all love to hear from you, so please send us your questions directly from the website or in YouTube. And remember, this case and all the previous cases are available in our website at ccclivecases.org. So let's go to rock and roll, and I'm going to put you directly with Dr. Sharma and Dr. Kinney.
Okay. Well, Dr. Kini will be coming. Pedro, thank you. And I know it caught a lot of people off guard today because we are not supposed to have the structural webcast this month. We were at a plan of every second month, every other month, supposed to be September, but knowing that structural growth is happening, so many diseases, so many valve procedures are there. So with the strong demand, as of this July, means this academic year, we are making it every month. So we are so much so actually where we do this whole relay, that conference room has been allocated to many other services because they thought we are not going to use it. But anyway, that's ours, and I know we made a lot of people unhappy, but hopefully our audience will make them happy. So welcome to all for our this monthly now. Will be structural webcast every second Tuesday of the month, and we try to bring a latest topic of interest, and clearly that will be made in the e-blast announcement of the valve in valve or redo TAVR, which is clearly becoming increasing entity, and we'll talk about it with my presentation. But just after introducing my usual staff here, and Dr. Gilbert Tang, our structural surgical director, Dr. Sahil Khera, our structural director at the site. Then Dr. Kini will be joining us right here. And then we have Dr. Lucy Safi. She's our echocardiographer today. I think she has been here once or twice before.
We wait for him and then he starts
now,
without
and then rest of the staff,
Yeah.
we have two fellows here, Penta and Akshay. So we have actually three structural fellows. We are total 8 interventional fellows and 3 endovascular fellows. And then we are imaging fellows. We one of the imaging fellows right here. We'll go through this. And this is the case where anytime when you do, I know that the tower is becoming minimalistic. So a lot of people are actually doing even without intraprocedural echo, just pre and post, no anesthesia, and of course early discharge is always there. We in America will not do the discharge on same day because of the DRG pattern, reimbursement pattern, because otherwise there is no ambulatory code for the tower. But I know some places like Canada, and so they are doing in selected cases discharge. But majority are going home the next day. But now, with the increasing use of this tower procedure of having almost like 100,000 per year in just in United States, I think globally probably it will be 200,000. The more and more disease entity will come of the valve is degenerated now. More so when we are doing in younger patients, now they outlive their lives. So in the past, you put a tower in the age of 85, patient is dead at 89, so we'll never know the tower degeneration. So clearly now you start doing in younger age, we're getting more and more patients, and this will be our focus, which we did last month, month before, similar type of case, and the new valves, particularly Evoke, TriClip, all those things will be done with this increasing our number of our structural cases. So with that note, we start our case of today. These are our supporters. And these are our faculty here. With our cardiac anesthesiologist is Dr. Morgan Montgomery. And so this is the case number 61. Redo TAVR for degenerated transcatheter aortic valve in a CKD patient using Sapien 3 Ultra RESILIA. So this patient, actually 73 years of age, had dyspnea and fatigue. And patient, as you can see here, patient is end-stage renal dialysis in 2020 and has a PCI at that time and has many other conditions, as you see, cancer and treatment with the hepatectomy, and then has incision hernia. So not a good surgical candidate. At that time, he had a tower using Sapien 3 with a left main protection in July of 2021. So just about 3+ years now, 3 years and 1 or 2 months, good ejection fraction, and then it's gradually started coming with the increasing gradient, shortness of breath, and so good medical therapy. Angiography has been done, has a small diagonal disease, so CAD is not the issue. Patient is the sinus rhythm, and there is no, I think there is the first DAV block in the latest ECG. But otherwise, as I said, this patient on dialysis, good medical therapy, and these are our TAVR CTA original. So now, maybe I'll ask Gilbert to comment on this. This was the original, because anything which I'll emphasize on our subsequent, my presentation, that when we are doing the redo TAVR, our very important is to go back and see whether it was done at the same institution or outside, that what was the factor, can we do better than compared to what it was done, maybe could have done better at that time. So this is all learning of this disease entity. So this patient had a TAVR here, right at Sinai, and that's the time was the pre-index TAVR CTA.
Yeah, so we typically ask for the outside TAVR CTA, the index one, for a number of reasons. The most important, which you want to see what the valve, whether it was sized appropriately, and whether that correlates the mechanism of failure. Number one, whether the valve would be expected to be oversized too much or undersized too much, causing paravalvular leak or valve degeneration. Second, you want to know the morphology. Are there any hostile calcium at the annulus or LVOT, that if you plan to pre-dilate the index valve, whether it will lead to risk of root injury? That's been anecdotally described. And also, is it a bicuspid valve or tricuspid valve? Because that can also matter in terms of, if it's a bicuspid, that's raphe that could be hostile to any kind of further expansion of the index valve. And of course, the left main height and the sinus height are also very important, because once you have the index TAVR in, it's very hard to measure those measurements. Next slide.
Okay.
So this is the initial TAVR. You can see that here. There was the angiography. Next slide.
There was the issue with the left main, so the left main protection was done.
That's right, at the time of, and you can see that there was no issue with the left main at all, and so that was fine, and we'll show you how the current valve has looked. Next slide. So these are the echo measurements initially.
So this looks like this patient within 30 days start developing the gradient. So now question is, if you go back to the expansion of the valve, and our baseline was good, right? Mean gradient was single digit. That's what we are always looking for. But expansion of the valve, let me just see if I can go. That if we see play of this valve seems to be angiographically expanded. I mean, many times we see a little dent like waist, which is not there.
Right. This is true size, which that's why it's important to look at the index TAVR CT to see is it oversized, undersized, or true size. This is pretty true sized.
Okay.
Yeah, for the 23 Sapien.
Okay, so now actually we'll ask Lucy on comment on this. So this patient had about 16.8, 16 was the peak gradient and mean gradient 8. We know if you do a hemodynamic, that gradient will be 4 or 5. Echo always tells us some gradient, and our studies have shown that residual gradient is a little higher with the balloon expandable versus self-expanding. With whether that translates into a bad outcome, which is a matter of debate. In the SMART trial, we saw it did not happen. But key is that there was a slight gradient in this case. Usually we get about 5. This was the mean of 8. Could we have done something different, Lucy is here?
No, I mean, those are expected gradients, less than 10 after a balloon expandable valve. And it looks great on fluoro. It looked great on echo. I think we did everything right here.
Okay. Now, 30-day, you see the rapid increase in the gradient. This is the patient hemodialysis. So is this, I don't know what you think, could be a recoil or what could be there now in this? Because it's such a high gradient of 46.25 at 30 days. And ejection fraction was good. There was no PVL.
Was a CT done?
Repeat?
Yeah. 30 days. I think if we have a gradient, we normally try to do another CT to see what is the real
I don't think the patient was symptomatic, right? The patient was not symptomatic, NYHA class 1. We're just basically looking at the gradient that was increased. So,
but what are you looking for, AK? Just tell our audience, what are you looking, why would you do the CT?
No, if there is a leaflet thrombosis, that's one. And other one, we don't know in dialysis patient. Despite the good, first time valve placement, could it be something that is causing valve degeneration? I think the only way we could have learned more probably repeating a TE or a CT at 30 days when we saw the gradient.
So that's a very good point. So halt or the subclinical valve thrombosis, which always have shown that if you are on anticoagulation, the incidence is less. But clearly, that is one of the factors of the rapid valve degeneration, and we do. In those cases, and actually we have seen some cases that, and I have one patient, we are ready to do a second valve, we did the TV, the gradient was 65, is about 1 year, and it was clearly halt, started anticoagulation, within 3 months, repeat, became single digit. So clearly once you identify that disease entity, which Dr. Kini just mentioned, that, it's clearly if you have identified now, many times would not, and this seems to be on echo, on the transthoracic echo seems to be a clear-cut, just the leaflet degeneration in this particular case. And then patient was asymptomatic, then started getting some symptom. Actually, echo was kind of identical, what was at 30 days. At 1 year, continues to do fine, and then has a recurrence of symptoms few months earlier now, in June, now having gradient much significant now. Mean gradient is almost 40, and 3 years later. This is the where patient has started having a recurrence of symptoms, shortness of breath, and that's what we presented there. So we'll show it today. So redo TAVR CT analysis, the TAVR was done. Any comments on that?
Yeah, so you can see that it's reasonably well expanded, but slightly under-expanded, you saw here. So that might be one reason for the increased gradient. But of course, Dr. Sharma mentioned the patient is young, on dialysis, and these patients are the highest vulnerable category for early degeneration, even with surgical aortic valve replacement. Even in TAVR, we see that as well. So it's not just a issue specifically to TAVR, it's a tissue degeneration.
I think in this case, I don't think it's true degeneration that happened in 30 days. Reasons for having such gradients within first 30 days is either you're pinwheeling of leaflets because of underexpansion of a valve, or there is actually halt in the leaflets. I think this patient's gradient of 20 to begin with was because of some pinwheeling of the leaflets. As you can see, the mean in the midframe. Midframe is almost always the area which is slightly underexpanded. The outflow and inflow look pretty good. I think this could be the gradient which is residual when the patient starts activity level, starts walking around, there's some pinwheeling of leaflets. And then after 1 year, that's when true degeneration or accelerated degeneration because of CKD started. I think that it seems to be a more plausible explanation than just a valve degenerating in the first 30 days.
I fully agree. I mean, to have that early has to be some mechanism, cannot be the degeneration. Very good points, very good points. Okay. So redo TAVR CT analysis.
Yeah, so this is important now. So as you know, Vinny Bapat and Miho Fukui and others have published this app that's available for download. You basically punch in the numbers that you find on CT, and they will predict for you in terms of the risk of coronary obstruction. That is really what we are here to discuss in terms of after the index TAVR, what is the risk of that? Next slide. And you can see that here, at least in the CT analysis, looks like it's quite favorable. And of course, we'll show you that on the angio, which is, I think, the highest resolution image to show you what is the true obstruction risk, because the CTs often have motion artifact or particularly booming artifact from the valve itself. You can see that here. Nevertheless, I think the app is very helpful. You see that we have some still images of the app showing that the color is green, meaning the risk of coronary obstruction will likely be low in this case for the left main, and the right is not relevant because the right is higher than the neoskirt plane, which is the top of the valve. Next slide. And you can see that that's kind of roughly where we would consider deploying this valve. I think this was drawn upside down, but in terms of the Sapien. But you can see that there's the bulky leaflet here with the angio. Then we'll actually show you here as well, showing that it should not be a problem.
So Anu, tell us, because Anu, you did say that you may not require any left main protection. That was we thought so.
That was prediction.
So
Can we show the angio images?
Yeah. This is the right now.
Yeah, so you can see the right is above the neoskirt plane. This is the angio. This is the left main.
So you have the left main of the last time.
Yeah.
You see that? We are able to engage above the diamond, the valve frame, and very easy. So right now we are going to place this second valve below that
Just
diamond.
a little bit below.
Yes,
Yeah.
just below. So going with that prediction, we should not have any issue with the left main closure. I don't even think we should do any protection.
So Dr. Kini has brought an excellent point, is that, this is a young patient. The question is, what valve should we put in now? And what the expected longevity of this second valve will be, knowing the first one only lasted 3 years. And so our rationale here is to use a balloon expander valve, and Dr. Sharma can articulate one of the reasons why we actually had a big heart team discussion, because obviously there are some hemodynamic benefit with a self-expanding platform, especially supraannular valve, but we have to talk about lifetime management now. Dr. Sharma, you want to?
So no, it's the same thing. That it is expected that clearly with the self-expanding valve, you'll get a better hemodynamics. And although the leaflet may be different, because the RESILIA may last longer than the current leaflet of the evolute valve, but that still need to be seen. There's no data to support one way versus the other. But the key is that this patient looks like not a surgical candidate, probably will see again in anywhere from 3 to 6 years. So therefore, you have to have another device which you will be able to do. So that will be your third TAVR. So question is, if we do the self-expanding TAVR now, and that degenerate, then what we are going to do?
Right, so that's the point. And Sahil can bring up the two options, right? There's two self-expanding platforms out there, intraannular versus supraannular. The concern is that now you have a tall valve in a short valve here, coronary access, and you can see some stents already there, will be challenging, whether you have commercial alignment or not, because now this Sapien 3 will be like a tube graft. The second point is that if that self-expanding valve fail, what is the next option? Because you don't really have another option other than the balloon expandable valve again, and then you would have to implant that valve higher to at least have some leaflet over, but then you can't do that because you'll have a native anatomy is already already blocking you. So I think that is the reason why we're picking the balloon expandable valve in this case. So here you want to comment on the strategy here?
I think we also have to think about the longevity of the patient here.
Yes.
You have to check the protoplasm. Patient with a MELD score of 20 is very symptomatic. So at this point, the goal of this procedure is to improve the quality of life, make sure the patient's able to do the activities of daily living, not necessarily to prolong the life or give them a longevity. So I think chances are using a balloon expandable valve safely without causing any coronary issues would do better for the patient than trying to optimize the slight advantage of a durability using a supraannular self-expanding platform here.
And therefore, at least now, once you do a balloon expandable, you are not worried about the coronary obstruction, right? Because
Correct.
of this aortogram, very good.
Correct.
Now, if you put a self-expanding now, still there is a chance of coronary obstruction?
No, not at all. But what I meant is that coronary access afterwards.
Yeah, afterwards.
For if this patient with CAD progression, but also if that second valve fail and this patient, you never can have a crystal ball, predict how long this patient will live, even though, yes, the comorbidities are there, but we've been proven wrong a number of times. We had a patient who was 80, had the first core valve that you put in, came back 10 years in 91 with a failed core valve, 10 years. That's a great durability, and now we have to troubleshoot to decide what to do. So I think in our mind, we think that the balloon expander valve will give the patient the most number of options in the future.
Mm-hmm.
Now, for the audience, although extensively discussed previously, alternatives, maybe somebody in the audience will say, well, this valve didn't work. Maybe the next one is not going to work. Which other, let's say, surgical alternatives to review that just for completion?
No way,
Sure.
because of the patient's liver cancer and the high MELD score, surgery is an inoperable case.
Yeah, but I think to Dr. Moreno's point that if some surgeon might say, well, let's say the comorbidities are not there, then I agree with you. Surgery, a TAVR explant would be a very, very fair option to discuss with the patient, as long as the patient is not high or prohibit or extreme surgical risk. Because obviously we need to have something that's more durable. Of course, this patient, given his comorbidities and age, already had a TAVR after a heart team discussion in 2021. We already think that the patient would not be a good surgical candidate. So that is the rationale. But Dr. Moreno, you're absolutely right that in our heart team discussion in patients who are not extreme surgical risk, we often talk about TAVR explant and redo TAVR as an option as well, particularly for patients who are not suitable for redo TAVR.
One thing I will say is that surgeon will also opt for a bioprosthetic valve here.
Yes.
So the nidus hasn't really changed. unless you tell me it's a mechanical valve. And remember, patient with a high MELD score, trying to anticoagulate a mechanical valve becomes really challenging. So if you're putting a bioprosthetic valve, I think this is a safer option for the patient than trying to do an extensive explant and trying to put a bioprosthetic surgical valve.
Correct.
And very good point. Also, on continuation of the same, the leaflet durability. I think now the whole field of the TAVR, besides optimizing the valve dynamics, whether intraannular, supraannular, balloon, is that how can we improve the life of the TAVR leaflets? And of course, towards that, the RESILIA is one of them, which is used in the surgical literature. They're very happy with this, very low degeneration. We start using RESILIA in the TAVR valve with the Sapien just about 2 years ago. So that will be another big difference here. And remember that also RESILIA data have shown there is a lower residual gradient by using the RESILIA compared to their earlier Sapien Ultra. So if the change may happen now is that we are using a different valve leaflet, which expected, I'm saying, that although time will only say that because RESILIA in the TAVR valve is being used only for 2 years. And we actually have now completely changed. All our Sapien valves are the RESILIA valves, and no difference. In the beginning, we were doing it for young people. And, we said, no, it's a good valve. We changed it to all. So all our patients with the Sapien gets the RESILIA valve. So that will be a difference here. And maybe we can do a little better hemodynamics. I mean, what can you do? You're a double inflation. Maybe you put extra CC syringe if necessary, if the gradient has not come down to single digits. So many other things we'll try to do, optimize here, knowing now that this was just a story of 3 years. Okay, we go back to our presentation. Anu, you want to say any other point?
Question to you, Gilbert.
Slide. Yeah.
We are talking about, how the leaflet durability can be done for the TAVR valve. Should we think of looking into the patient factors, genetic factors, especially patient with renal failure? Is there any predisposing factor of the patient that's responsible for accelerated degeneration of the valve?
Yeah, no, they're absolutely right. So tissue science is a very challenging topic. As you know, the body has a lot of redundancy built in. There's the anticoagulation pathway, but there's also the metabolic pathway. And we all know that, like you said, the patient on dialysis have a different metabolism. And you've seen a lot of patients that in the clinic with these, and typically younger patients and on chronic dialysis. So I think we need to do more molecular biology work to better understand this. But I agree. I think this is still a black box to a lot of people out there.
Yeah, to expand on that, Anu, the parathyroid hormone is the one that mediates dystrophic calcification outside the bones. And these patients could have a parathyroid hormone above 1,000. So, maybe that's the relation between the chronic renal hyperparathyroidism, tertiary hyperparathyroidism, and dystrophic calcification.
Yeah, and this patient actually had the PTH level that was tested by the referring cardiologist, and that was normal. So access was fine. So this is there. Dr. Safi, you're going to show the latest echo now?
Yes.
And so that's our plan today is Redo TAVR with the 23 millimeter Ultra RESILIA in degenerated with no left main protection now
TAVR.
and the TE guidance, right? The patient has the TE guidance. And idea is that we try to do as best possible so the issue about the leaflet impingement is gone and we can go to the fluoro and the presentation of the case now. Okay. Dr. Safi, tell us what you are seeing there. This is the live echo now.
Yep, live echo now, assessing LV function. Appears to be normal. You can see diffuse thickening, hypertrophy of the ventricle, RV function, mild hypokinesis at the RV apex there. And then now looking at the bioprosthetic valve, so this TAVR valve in the center of the screen, you can see that 2 of the leaflets are restricted in motion, and you can also assess where the commissures are in relative to the valve. And here with color Doppler, you can see that there's flow clearly down the left main, and there is also some aortic insufficiency, mainly valvular. There's no evidence of paravalvular leak. On long axis here of the TAVR valve, again, you can appreciate the restriction of the leaflets and the thickening of the TAVR valve leaflets. And again, full assessment of valvular or paravalvular leak. You can see it's mainly all valvular, mild to moderate aortic insufficiency with no paravalvular regurgitation. So LVOT dimension is normal 2.0. And some of the gradients now, you can see the LVOT VTI is also in normal range, ranging between 24, 25. And then the gradients we got on T today, peak velocity of 3.9, and then a mean gradient of 37, consistent with severe aortic stenosis for this patient, probably from degenerative valve leaflets. We took a look at the annular area and they correlated well with CT, confirmation here 4.2 centimeters squared for area at the annulus. And then just looking at all the other valves, you can appreciate the mitral annular calcification on 3D in the surgical view here. He had some mild to moderate mitral insufficiency as well. And tricuspid looked normal.
Mild to moderate.
Yeah, no, I think that's a great point that you show on echo that this valve is actually commercially completely misaligned. So, you know, we talked about redo TAVR feasibility in sometime leaflet modification, in, you know, such as basilica or shortcut. This would not have been possible with this particular orientation. That's why alignment of the first valve is so important, irrespective of age of the patient. You just never know when they will come back.
Yeah. Perfect. Okay, Manu, ready? What's the plan now?
Now we are going to dilate. Other question, Gilbert. Remember, we are such a believer of lesion preparation before we do stenting of the patients, right? In calcific lesions and all that. So during the surgical replacement, remember they clean, they remove everything, they make space.
That's right.
That may be the issue also, no?
That's right. That's why you want to talk us about the double tap now with the RESILIA valve. Why don't you tell the audience about that?
Yeah,
We've been doing for some time now.
We've essentially, I think it started because RESILIA was a little harder, but now we got used to inflate that valve. What we used to do is do the first placement and then again go back and dilate it. But that's, I'm not saying that. For in this kind of patients, remember we are discussing what could be the reason for the valve degeneration.
But we find that, and actually their papers will be coming out that if you do a double tap technique, your frame actually expands a bit, even fluoroscopically.
Yeah. Sine? Now tell us the reason for a BAV in this case.
So
again, we're trying to expand the first valve more, off pacer.
Okay, so
but
you
what
have
size
to
balloon
expand
you use?
24.
Okay, 24, right?
Yeah.
So therefore, bigger balloon used to try to expand the frame of the original valve.
That's right, because actually the Vancouver group has shown that if you don't do that, you cannot expand the first frame further when you have two frames in the way. That's been shown on the bench, and bench is the most, basically model, right? If you can't do it in the bench, doesn't mean that you can do it in the patient. So even that's why we are doing that now to prepare. We call it to prepare the landing zone, just like what you would do in the coronary well, right? You would prepare that before you put the second stent in the artery.
Yeah.
Yeah, would you play the balloon inflation again?
Yeah. No,
sure.
the balloon inflation is one, but you can. Okay.
Here, yeah. So let's talk about it. I think it's not perfect, huh?
No, remember, you're not going to expand all the way uniform. That's still the native annulus. You don't want to rupture the annulus. So the key lesson is do not too aggressively pre-dilate. Otherwise, if you have an annular calcium at the index TAVR CT, you can rupture the root, and that's been reported. So that's why it's so important to look at the pre-index TAVR CT to see how aggressive you can do this. You might not be able to do it, actually, sometimes. If there's no room, you don't want to do this and obstruct the coronary either, right? Because we did do the protection first time.
So this is actually a perfect pre-BAV. You can see the valve is expanding way beyond the previously placed valve. And you see the halo around the balloon inside the valve, Dr. Moreno? That's the old degenerated leaflets. So you cannot, just like a surgical valve, you cannot be very aggressive in these cases. You just want to optimize. If the size is okay, if it's an undersized valve, then it's a different ball game altogether. If it's a degenerated valve, you don't want to be very aggressive.
Yeah, no, Sahil is absolutely right, because also there's a risk of these debris can go to the brain, right, in terms of embolic event. And also the leaflets have a certain thickness.
So I guess one of the issues here will be the differences in the pre-dilation when you have a surgical implanted valve that now is degenerated versus a TAVR. Different approach, isn't it?
That's right, Dr. Moreno. So you can see the surgical valve. We talk about fracture or no fracture. Beyond
Exactly.
that, you can remodel in certain valves, but with the TAVR, it's a stent frame. Just like in the coronary world, you have a stent. So you need to prepare that, before you put a second one in. I think that's the principle of this. But to Sahil's point, these leaflets do have thickness. So even if you use a 24 true balloon, in your final valve deployment, you'll see with the frame, you're not going to be touching frame to frame because remember, the first 23 S3 leaflets are still there, right? It's not against a bare metal frame. So now you see we just crossed, let's just flow save that.
Yes.
Can we flow save that? Okay.
So also in very degenerated valves, it facilitates valve crossing also. You have to do a pre-BAV.
So I'm going to go in a little bit.
Yeah, we should.
That's good.
That's
That's
very
good,
nice.
right?
Yeah.
Yes.
So we are not aiming for outflow to outflow because we want a little bit of a leaflet overhang for the coronary access and the next future valve. We don't want this valve to be above this first valve because then you actually, your neo-skirt plane is going to be higher. You don't want that to happen. So this is, I think, great. And you can see there's no parallax with both valves, which is ideal because sometimes you don't. You actually have parallax in one of them. So what that means is that either way, you have to do extremely slow inflation. And we're going to tell our anesthesiologist, Morgan, that we're going to have a long pacing run. You might have to resuscitate the patient afterwards so that everyone is prepared. Okay?
Now, Gilbert.
Yes.
Are you happy where the valve is?
I would this is
go in a little bit.
I would no, actually this is a good starting point. Remember the valve still foreshortened from the bottom, but also a little bit from the top. So you don't want to be too ventricular. So this is not a bad spot, but prepare the valve might go deep. Okay. So you might have to prepare to
push the wire actually.
Let me
let Gilbert take the wire. Yeah. Okay. Pace 180. This is going to be a very slow inflation.
Slow inflation, so you can adjust it.
Direct.
Okay.
Okay.
180.
May have to.
It's not capturing. So 120.
It was.
150. 180.
Good.
Thank you.
Okay, good.
Very nice. Good.
Okay, go.
Good.
Yeah, yes. 2 millimeter below. Good.
No, perfect.
Keep going full. Okay.
Keep pacing, keep pacing, keep pacing.
Okay, off.
Off. Good.
Back up.
Back up pacing.
We'll
Come out a little bit more.
Yeah,
okay.
We'll
do one more post here.
Yep.
Want to do an aortogram just to see?
Sure. Let's do aortogram.
One more.
One more. Okay.
One more. Yeah.
We're
going to do a second inflation just like we do for coronaries. You know these, and as I said, I always was a believer in that. The two inflation definitely do the better expansion.
Beautiful clearance.
So the key here is make sure that your first expanded valve has not obstructed the coronary, right? That's the key.
Yeah.
Because you see the second valve did not really expand the first valve anymore.
Okay, we're going in.
Yep.
Now you need
Flex
to put
again.
extra CC, or is the same thing?
I think it should be good. We are already plus
We are
2.
+2. Okay.
So we are 23 plus 2. Okay.
Okay,
so
we're
already a little more than last time.
Going up again.
And do a
180.
180.
Make sure pigtail is clear. We are going to do a hemodynamics.
Okay. 150. 180.
Okay, good. Good.
Very
Full,
nice.
full. You're full?
So you see it's better at position of the second valve versus the first one. That's what we're doing
Keep
this.
pacing, keep
Keep
pacing.
pacing.
Off, off, off.
Okay,
Back
now
up
the pigtail.
and
Pigtail ready, please.
resuscitate. Thank you, Morgan.
Load the cap, load the cap.
Good.
Walk it out.
Let me know
Let's
when you're
get a
fired.
pigtail. Let's do hemodynamics. Dr. Safi, can you look at some images?
Thank you.
So I can tell you here, the wire is very critical, as Dr. Sharma has mentioned here, because Dr. Keeney can pull back, but then you're not going to be coaxial right to the second valve. And it's not that easy because you're rubbing against the tissue leaflet of the first valve. So the key here is to, what I did was actually apply a little bit forward pressure on the wire to stand the valve up so it doesn't come down. Because last thing you want is the valve going deeper. Same thing, especially for self-expanding valve, inside balloon expandable valve, or vice versa, with a balloon expandable valve, inside a self-expanding valve. So this is a very important lesson for the audience to make sure that you have the wire support during the procedure.
Get a J-wire. Get me a J-wire, please.
Lucy, how does it look? Can you show the echo? Yes, you're showing echo now. Good.
Let's go bring the echo to the mainstream.
Yeah, Lucy, can you comment, please?
Yep, so far it looks really good. I already took a look at the long axis. So here you can see on long axis, no PVL and no valvular leak.
And what is the mean gradient from your side?
Yeah, let me go and check.
It's always nice to see laminar flow afterwards.
Mm.
And get a
Zero
good number.
everything? Okay, good. Can we show the hemo now?
Hemodynamics, please.
Now let them get their gradient. So we'll to predict what will be our hemodynamic gradient. I always do that. Let's see what is the gradient on the echo.
So there's a little bit of ectopy, but the maximum mean is only 7.
Good. What is that?
7.
Mean of 7, peak of 13.
Fantastic.
Those
This
are a little
is there.
switch to
So
me.
I can tell you the once
and
it is
6.
7 or 8, usually our hemodynamic gradient is 0. Let's see what we have. Show the hemodynamic gradient also now.
Has to be 0.
0. So that always has been shown in the few papers all on that issue. The echo, remember there is a whole where you take instantaneous velocity and all, but clearly our goal is you wanted to bring it down to in single digits, and we have achieved that. Aortogram has already been shown. And the whole question still comes. I know we do give a 1 or 2 antiplatelet therapy, but many of these cases, could they benefit from giving the anticoagulation? Always a debate. We know that anticoagulation is good for the leaflet, but it's bad for rest of body, including the bleeding. So Galileo trial and just showed the same thing. Leaflet was better, but at the expense of intracranial hemorrhage and so. So that's a big issue remain. But I think in this case, I think we've done a better hemodynamics than the last time. And I really wanted to emphasize on wanted to show that how balloon expanded the original valve. Look at this one now.
Yeah.
You can see, if you can go and Flora now. So Lucy, from your side, things are good now, right?
Yep,
Yeah.
beautiful.
Yeah, look at this one. So key that when your balloon being inflated, see the original, this is the original valve expanding with a balloon inflation.
Look at the difference. Yeah.
Yeah. Yep. Look at this.
Yep.
Yeah, so I think that probably these are the multiple steps which were done to improve the hemodynamics, so that the story will be the same what happened in this patient with the 3 years. I mean, need to be seen. But I would say that we have different leaflet, better hemodynamics, little bigger valve, 23 plus 2, and double inflation. And I think all these contribute with a 0 residual hemodynamic gradient and single digit, even much lower gradient than what was left last time, despite the valve in valve. Either will go long way to give us extra, maybe 5 to 7 years in this case rather than 3 years we had first time. Okay, now you're going groin closure, right? What's the?
Yeah, I think we're done with
Yeah,
the
we're
case.
going to
Okay.
take the catheter
All right,
out.
so let's go back to our slide presentation.
We could give anticoagulation at least 3 months. First 3 months.
At
No,
least
but this is a liver case also.
Yeah, if we
No,
can,
but,
at least 1 month.
PTI
At least
and
1
our-
month, and
So I think that's the short term. Will that better or
On the
not?
overtime?
We need to be seen. Okay. So let's go back to our, today I said that recent publications in the Redo TAVR field. The word is the Redo TAVR, or they call TAV in TAV. Compared to same, TAV in SAV. Pathophysiology, Redo TAVR outcome based on the valve type, and Redo TAVR versus native TAVR, the registry data of the TTE of 1 year outcome. So therefore, let's talk about, I want to stop here for a few, 1 or 2 minutes on this, and we'll take all the opinions. Remember the guidelines. The guidelines are in UK or European, 75 years. Less than 75 SAVR, more than 75 surge the TAVR, and particularly those who have a higher Euro score. Now in America it's a little different. It is 65 and 80. Less than 65 go for surgery, more than 80 goes for TAVR, and of course in both the groups, in between you have a shared decision making. So now question comes down, and we know the lifetime management of these TAVR patients. No longer we are talking about extreme risk or no risk. I mean, the patients are very elderly, but we are doing these cases in the younger age. So considering tissue valve, life about 10 years, whether it's a surgery or TAVR. We have shown many trials now. Notion trial and all have shown the life of the original TAVR valve. RESILIA is not counted in there. So it is about the same. If let's say it's about 10, and the average life expectancy of a patient in America is 82. 80 to 82. Procedure done at age of 60, 65 will likely need 2 more valve procedure in lifetime. So therefore, this is a decision making which we talk about this particular case, that if you do the self-expanding valve now, and then you do a TAVR later, will be a big issue in terms of the coronary impingement and so. So therefore, I think this all has to be considered, and this all thing can change if the TAVR valve, the leaflet can last 20 years. I mean, that's if we can have that type of a valve with leaflet last, all these guidelines and all these things will change. So basically, we know the valvular degeneration, structural valve, non-structural valve thrombosis and endocarditis, and based on the valve morphology, we talk about it, there are only morphological changes, and there is a moderate hemodynamic and severe hemodynamics. And also, at least in the TAVR arena, this concept is coming that compared to the surgical valve, you just let it degenerate. But in the TAVR valve, why not you can intervene when it is in the middle, not getting to the full morphological deterioration. And this actually is part of the complete TAVR trial. Complete TAVR is inbuilt in that you do a yearly hemodynamics, but that's a balloon expandable only. And if you start getting a gradient of about 40, do the balloon valvuloplasty and increase the life, and don't wait till it becomes a severely deteriorated. So this whole concept of the balloon valvuloplasty may change. So the question is, who degenerate the valve? Now, TAVR degeneration will occur. If we take our numbers, we did for last 2 years about 500 plus TAVR, and we get about 10 to 12. So it will be about 2% overall you take. Now, this is, if you year before, but maybe 1%. So more these patients will live. And because many times you will not see the degeneration because they're done in elderly and the patients have died from non-cardiac causes. So we'll never know. So now why this is coming up is because we are going to the patients with a less comorbid conditions, and they are outliving the TAVR valve life. So that's where the whole issue will. We know every TAVR valve will degenerate a little bit. Every year you follow them. And of course, there are various factors which cause more degeneration, and compared to the peak gradient at discharge, valve in valve, small the valve which is less than 23 millimeter, severe patient prosthetic mismatch, and absence of VK at discharge. Clearly, all the trials have shown patient is on anticoagulation, they have a lower valve degeneration, but may have other things as I mentioned. So this is a big issue, as you can see. And other factors which we know, younger age, higher BMI, antecedent disease and commissioner misalignment point you made. So many of those cases actually have a higher TAVR degeneration compared to otherwise. So there basically remains. Then the question is what to do, whether you put a TAV in TAV or you do explant. So there are many registries, and one of them, Gilbert, the PI, I'll discuss that a little later. The key is that TAV, you can do explant, but it's associated with higher mortality and so, but you will do it only in the cases where there is an option. Like this particular case, even if it comes back second time or third time, there is no surgical option. So this is like not a true comparison, because when we are doing a redo TAVR, we're probably doing it in the simpler cases, and of course the very extensive cases are getting the TAVR explant. So that always associated with the higher mortality. The data have shown with the 30-day the stroke rate is about the same, but mortality is higher, pacemaker rate is same, and of course compared to repeat TAVR, if you take the data for both 30-day as well as the 1 year, it's almost double in terms of the odd ratio. So yes, and part of that is experience. So this is again a new disease entry for the surgeons. Because a lot of adhesions compared to the original. So many times we always need to think that if we know the patient going to outlive the life of the valve and is a good surgical case, even at age of 75, probably it's better to do the TAVR, to go for surgery, and once it degenerate, then you do the TAVR. So this is whole issue. A lot of people are different. They say, you know what, why not at age of 65 or 60, do the TAVR now, take the explant at age of 75, and then once that's valve degenerate, do a surgical valve, and then degenerate, then put another TAVR valve. So I think this is something which I have our experts here. I'll ask all three of them to give one line opinion of where the field should go. Right now, recommendation basically is young age, whatever, 65, 70, surgery first, then TAVR, and then TAVR. But what is against having a TAVR, surgery, and then you have at least 2 chances of TAVR? Anu?
I think number one is a patient preference. Number two is the anatomy. Means if there is concomitant extensive CAD and valvular anatomy that is prohibitive for TAVR.
Yeah. So
3 points.
Gilbert?
Yeah, like to Dr. Kinney's point, I think if you have this, we're talking about isolated aortic stenosis, not talking about concomitant CD or multi-valve disease.
Yes, yeah.
I think the question to her point about anatomy is, can you get the best result possible with whatever valve you choose for the patient the first time? Because if you're planning for explant the second time, which I agree, when surgeons do a better job in making sure these patients do well, is that you want that first runway to be as long as possible. I think that if you have a hostile anatomy, you're not going to have the valve well expanded, you're left with PVL, you're doing a patient a disservice. That's I think my opinion on which sequence, whatever the preference, patient preference, but we need to tell the patient this is the anatomy we're working with. We think that option A or B would be better for you in terms of longevity.
Yeah.
So I think that's a very good point. If patient is a candidate for both TAVR and SAVR, I would choose TAVR first. And I think you should optimize your initial valve implant, whether it's a self-expanding intraannular, self-expanding supraannular, or intraannular short frame valve. Just choose your first valve well and make sure you have the best result for your patient, and then everything becomes easy. So I think my choice would be TAVR first nowadays for isolated aortic stenosis.
So actually, that's a very interesting statement, and it goes with what is happening at present. There is a small registry, and then you presented the data on the TVT that almost
US.
60 US TVT registry that almost 50% of patients at age of 65 or below getting the TAVR in America, and this against the guidelines. But we also know they then have a faster degeneration.
Right. That's why I think this is such a salient topic that we're talking to the audience right now, because it's coming. We're seeing more.
But you have to follow the guidelines.
You have to follow
cannot
the
do
guidelines.
it in less than 65.
Correct. That's right.
But this is happening in America. And this is Gilbert's redo TAVR of clearly the follow-up of the patient, TAVR explant versus redo TAVR. And very interesting, few observations that when you do a TAVR explant versus redo TAVR, and particularly the mechanism, right? One of the mechanism which you highlighted, Gilbert, you want to emphasize on this case, the PVL versus the leaflet degeneration.
That's right. So if you're a prosthesis patient mismatch after TAVR, you can't really do another TAVR. That's the bottom line.
Key.
Yeah, you have to do surgery. I think that is really the key. If you have structural valve deterioration, as long as anatomically okay, like in this case, then redo TAVR is definitely better. But if you have surgery, as long as you survive up to 1 year, then the survival curve did not really change. But certainly, yeah, if you have the less invasive, safer option, I think that's the right thing for the patient. But make sure you don't get severe PPM for the patient when you do TAVR. That's the bottom line.
And the key is, in this paper, they have the 30-day, in-hospital 30-day and 1 year, and all difference was because of the in-hospital event.
Correct.
So whatever 8-9% which was higher, if you take that out with the landmark identical, see on the top right side, you have the higher mortality of the in-hospital, of the TAVR explant, and 30-day and 1 year. But that 9% is driven by your first third in-hospital event. So that's key is that once you come out of the one, they do quite well subsequently. Then many of the issues which we need to worry about, we have spoken quite a bit of the neo-skirt, the leaflet overhang, expansion of the index TAVR valve, and the leaflet deflection. So now question comes in, how can we, in the most cases, I want to just read this sentence, the leaflet of the index prosthesis will be deflected towards the stent frame. If the leaflets are not sufficiently deflected, the remaining gap between the neo-skirt and the first valve frame may reduce the risk of coronary obstruction, albeit challenging future access to the coronary ostia. So that basically is that
that concept is more unique for the accurate neo valve because it's a low profile frame. So the leaflet, just like when you do the surgical valve, you can actually deflect out beyond the dimensions of the inside inner frame. So that's what they were talking about. But that's only unique for that particular platform.
Yeah, perfect. And then I think the coronary obstruction, which the neo skirt and the new coronary risk plane, and you have to be very careful which valve you do, what depth it is. This is a very nicely demonstrated in many of these the pictures which I have made it for the coronary re-access. Maybe we should have a re-access the app.
If I make next app, I'm only going to have Gilbert talk. Because I see the other app he mentions in every talk. And it has to be highlighted like that in our coronary type also.
Yeah. So then, of course, it's the intraannular balloon expandable versus supraannular. They have a little different in terms of coronary engagement, and so which I have put an analysis of the index tower valve. We have emphasized on this point, and the question comes is that if you already have a failed self-expanding and others, what valve do you use? So I think we probably is the usual the same size with a 3 millimeter difference. What will be with the original one?
I mean, the combination, if you have a short valve, you put a tall valve in. If you have a tall valve, you put a short, you don't put the same valve because, then your neo skirt is very high. So I think that's what they're trying to show you in this table here. And for accurate valve, the only option is the Sapien. So there's no other option.
Unless you have a 26-29 intraannular short valve, you can do short and short. That's not a problem.
That's right.
Good job.
And of course, the TAV in TAV, many studies have shown, and one of them I'll speak about, that it's a safe, appropriate cases and as good as the first one. And then, of course, we talked about conduction disturbances, not much higher. Valve thrombosis, there is some theoretical benefit of the anticoagulation, but not has been shown. So now basically is that if patient has structural valve deterioration, the question is, do you do redo TAVR is feasible or redo TAVR not feasible? And it goes down to our basically is the structural valve that any major concern of the coronary flow, access impairment, residual patient prosthetic mismatch, those are inappropriate for redo TAVR and they should go for surgery. Right? I mean, any other highlight we need to make on this nice algorithm? Yeah. Sahil?
No, looks great. I think can't treat patient prosthesis mismatch with TAVR.
And PVL can be treated. We did the case last month.
Absolutely. So that I would sort of agree with. I think depends on the mechanism of PVL. So if your valve, it's a depth issue, yes, you can fix it. If it's truly an undersize issue, you can fix it. But if it's because of a PVL because of calcification, extreme chunk of calcification, I think it becomes very hard in those cases to do a TAV in TAV that may or may not help your PVL. So it depends on the mechanism of PVL.
Okay. So I think just to say that which type of valve do you do when TAVR in TAVR, TAV in TAV, whether you put the same valve, the self-expanding versus balloon, as I mentioned that we try to do a different, the valve, and all the data have shown that this is the valid alternative, but whole focus there is not only the hemodynamics, most important being the coronary access. How are we going to do? And this I described it. So one which is important is the data from which valve should you use. This is again redo TAVR according to the initial and subsequent valve type. They had a large number of patients and they went through a few of the propensity matching and present the data that which valve is better. Now, originally, as you can see, these are basically the self-expanding in the bottom, balloon expandable on the top. Balloon expandable comes a little early when they have degeneration compared to self-expanding. So that's one. But now initial valve type or subsequent valve type, whether you need a balloon or self-expanding, have an identical outcome. There are some differences. The initial outcomes of valve type and whether initial was balloon expandable or subsequent different valves, self-expanding or balloon, 30-day outcomes was not much different. What basically was the difference which was noted is the residual gradient. As you see in the bottom, that if you use a self-expanding valve, your gradient was lower compared to balloon expandable valve. And this basically is shown clear. So therefore, anytime you'll use, and we know whether this gradient means anything, we do not know, but clearly the lower gradient will be once you use a self-expanding valve. In this case, you can say anything because it's a zero. It cannot be less than zero, but yes, that has been shown for the initial valve type. The regurgitation and so is not much different whether you use it one valve or the other. So this is the central figure showing the only difference is the residual gradient once you use the balloon expandable versus self-expanding. Any comment on this, Gilbert?
Yeah, no, I mean, you know that Raj Makar's paper from TVT registry looking at, all balloon expandable valve, that also show the same thing in Lancet, that if you have balloon and balloon, the gradient is a little bit higher than balloon and non-balloon expandable valve. So I think just the platform and the combination. So, but we typically like to switch back and forth for the hemodynamic reason. But of course, that as you saw in today's case, that sometimes it's not possible and probably not advisable.
Beautiful. So this is what the next paper which you talked about is about the Redo TAVR registry for by Raj Makkar of large number of patients, native TAVR versus Redo TAVR. They matched it, but overall, yes, there's not much difference. So selected cases, you do Redo TAVR, the initial complications were numerically slightly higher, but not significant in any part. No need for bypass surgery or conversion to open heart surgery, and identical outcome up to 1 year. 30-day as well as 1 year outcomes were identical in both the groups in terms of the death, stroke, and individual readmissions and so. What is shown as clearly that you'll have a higher residual gradient in the Redo TAVR group compared to the native. So that's the only thing. Secondly, also, you have a little higher paravalvular leak originally, and of course it will change, but these are all balloon expandable. We don't have much answer on the self-expanding for the Redo TAVR.
Not yet in terms of TVT registry. Yeah. But also remember, this is not RESILIA either. Yeah. So I think that's a little bit different. But I think we need to, like you saw in this case, that you need to post-dilate, afterwards. Maybe they don't, because then remember, you have frame against frame plant tissue. So you need to post-dilate to make sure that you don't have a frame-to-frame leak. So that's, I think, that's an important teaching point.
Absolutely, and this we know. In this particular case, we saw the gradient we left at time 0, and gradient much lower now. Yeah. So I think the preparation of the valve may make it different. So let me just complete it. Take home that with widespread adoption of TAVR procedure in all AS risk patients, over 100,000 TAVR annually in USA alone, we'll be facing the increasing problem of TAVR valve degeneration over time. So just to give the idea, so I think it will be, in my opinion, around 2%. So remember ISR. In the cath lab right now, it's at 10% of the PCI are done with ISR. So same way, going forward, we probably 2, maybe 3% the TAVR will be done for the Redo TAVR. That's what my expectation, that's what we have seen. 8 to 10 of the 500 plus. And so. Hence, we need to start focusing in depth on this new disease entity as to the cause, mechanism, and appropriate management. We'll still may not have surgical option and will need another 1 or 2 TAVRs in their lifetime. Most common mechanism being TAVR leaflet degeneration, hence research on leaflet durability like RESILIA will go a long way prolonging the life of the TAVR patients. Second, TAVR explant continues to be troublesome and form the higher in-hospital and 1 year mortality. Versus Redo TAVR, clearly with increasing experience in this field, will bring down the surgical mortality. Some data did show about 6% mortality now, which used to be about 13-14%. Then Redo TAVR using either self-expanding TAVR or versus balloon expandable have similar clinical results, but lower gradient after self-expanding, as we know, for whether it was the original self-expanding or follow-up. Then selected match AS patients in hospital and 1 year clinical outcome of the first time TAVR are similar to Redo TAVR with balloon expandable valve as to the endpoints of death, MI, and stroke. Long-term data, we need to be awaited whether it will make a difference. So let's go to 3 questions. Following are the true statement about the Redo TAVR valve procedure compared to the initial native TAVR valve procedure, except means what is wrong? Higher coronary obstruction, higher residual gradient, higher permanent pacemaker, higher PVL. Clearly the pacemaker rate is about the same. Following factors are associated with higher transaortic gradient and higher valvular heart degeneration incidence at follow-up, except Valve-in-valve procedure, lower BMI, use of anticoagulation, less than 23 millimeter TAVR valve. As you know, the higher BMI is associated with the lower BMI is favorable, everything else is negative.
Huh?
The
Wrong
lower
question.
BMI. No, long question. No, accept. The lower BMI is associated with the better outcome. Everything else is a bad outcome. See, that's the lower BMI is the wrong answer. Accept means what is wrong. The last question, following statement not true regarding the outcome of matched redo TAVR versus native TAVR up to 1 year, similar mortality, similar stroke rate, similar major bleeding rate, and similar residual post-procedure. So same thing. It's basically not true is the residual gradient because that's a little higher. With that note, we complete our presentation for today. Pedro.
Very good. Well, thank you so much for the heart team of the Cath Lab for this super exciting case. Congratulations for the audience. We have this case recorded already this afternoon in our website, ccclivecases.org. Most importantly, today was our first case in which we're going to do this every month. It's going to be the second Tuesday of every month. So September the 10th will be the next one. See you then. Thank you so much.